Okay. I think the sugar hit in. It kicked in. All right. Here we go. All right, we got our next presenters right here. I'm excited about this to hear what they have to say because I know them both personally. They are a couple of really good neuropsychologists. They are, what can I say? They're a dynamic duo. We see them as they do the Thrive workshops with us, which is a cognitive behavioral therapy workshop for our TBI, small group of TBIs over 13, 14 weeks. And we see some amazing outcomes with those guys. And these guys, they really take it very seriously. But suspect number one is Dr. Stephen Doherty. He is a fellow at the PRI Psychiatric Research Institute at UMS. His primary interests are involved in cognitive rehabilitation, serious mental illness, and acquired brain injury. And the Crystal Fullen, Dr. Crystal Fullen, is a clinical neuropsychologist, and she is in the Department of Psychiatry, Neurology, and Trauma Surgery at UUAMS. In addition, she also provides neuropsychological services to include assessment, intervention, agitation management at Baptist Health Rehab Institute. She's been such a great partner with us, and we just love her to death. So if you'll welcome them with a warm welcome, we'll get them started.
Good afternoon, everyone. My name's... Can y'all hear me okay? Cool. Good afternoon, everyone. My name's Steven. And so I'll be working with Dr. Fullen today, and we'll be talking about de-escalation techniques in an acute care setting. And so we do have some objectives we want to go over before we really get into this talk. And those objectives are A, what is de-escalation? So by the end of this, you should have a good understanding of what de-escalation is, what it might look like in acute care settings, as well as some examples of how you might practice it. We want to talk about different types of warning signs. So early warning signs of behaviors that a patient might be becoming agitated. So we're looking at things like increased heart rate, for example, or anxiety. We'll go into that a bit more later. And when we're able to identify these early warning signs, it can help improve care outcomes and give us some things to work with and targets for de-escalating. The next is to apply effective communication techniques. The basis of a lot of what we'll be talking about in terms of de-escalation is communicating effectively. Oftentimes, when we're talking about agitation or aggression, one of the foundational aspects that causes this is difficulties with communication. And that can occur for a number of reasons or a number of different conditions. And the last is how to implement de-escalation strategies in practice. And so we're psychologists or neuropsychologists, and so we like our vignettes. And so at the end of this, we'll be having some audience participation. I'm looking forward to it. You may not be, but you're part of this. And so as we get started, I want to talk about what de-escalation is. So when we talk about what de-escalation is, it's a series of techniques or strategies that can help manage or reduce the severity of agitated behaviors, of interactions, and it's really the opposite of escalation. So we're talking about steps down versus steps up. And then in an acute care setting, so I know we have a lot of different providers here today. So we might have outpatient providers, inpatient providers, and so when we're talking about an acute care setting, our recommendations are still helpful in most environments, not all environments. And so an acute care setting is a level of healthcare in which a patient is treated for a brief but severe episode of illness, so for conditions that are related to a disease or trauma or during recovery from something like a surgery. All right, and so therefore, before we talk about de-escalation strategies, de-escalation techniques, we want to talk about why they're important. And so de-escalation techniques and strategies are repeatable and teachable strategies that can be used to help manage changes in cognition or emotion. And you're all providers, and a lot of you are providers. Some of you have experienced agitation and aggression. And so what that might cause in a care setting is it might impact care. A patient might not be as involved in things like speech therapy, occupational therapy, physical therapy. That might have impacts on their health. It also might have impacts on things like disposition planning. Sometimes we need things like a COG eval to get them a referral to rehab, such as Baptist or other facilities. And if we can't get that referral, it can actually be dangerous for the patient. It can cause negative health outcomes. And if our agitation is not managed, it actually causes safety issues for care providers. So a patient might be verbally or physically aggressive, which puts care providers like you all, or a lot of you, at risk. And so it's important to be aware of early warning signs, to have an understanding of what de-escalation techniques are, and more importantly, which I'm going to touch on next, is what is agitation and kind of symptoms or conditions that make someone more at risk to experience agitation. But before I do that, I want to just take a second to note, managing agitation using de-escalation techniques, whether a patient is mildly, moderate, or severely agitated, has been found to have positive outcomes on patient care. So throughout their entire stay. And that's really important because it kind of shows or emphasizes that de-escalation techniques are positive and helpful regardless of level of severity, and just something to keep in mind during routine care. So agitation. What is agitation? Agitation might look like a lot of different things, and it might mean a lot of different things for different people. And so broadly, agitation is an atypical response, so atypical behaviors or verbalizations, so behaviors that don't quite make sense, that are often agitated. So we're talking about outbursts of anger, emotional lability, restlessness, inappropriate vocalizations, so cursing, slurs, that sort of thing. And it's important to note that there's diagnostic criteria for agitation. So the first is, what's causing it? Can we find a medical, a psychiatric, or a physical condition that's related to this agitation? Can we find a root cause that we can treat and manage? If so, let's do that. That can help treat this agitation. But if it's not, that's often what we're looking at. It's unintentional. It doesn't have a root cause that's easy to identify or that we're able to identify. And so while it's hard to remember this, especially in the moment when, let's say, a patient's spitting at you or cursing or yelling at you, agitation is often unintentional. They're not meaning to do this. They're having difficulties expressing themselves. They're experiencing pain, confusion, etc. And because of all these factors, they're unintentionally doing behaviors or vocalizing in ways they might not normally. And so next, I'll talk about common presentations that are likely to experience agitation. And so this is the Traumatic Brain Injury Rehabilitation Symposium. And so the first one I want to talk about is, one second, there it is. How to keep you all guessing. So traumatic brain injury. And so up to 80% of patients who experience some form of traumatic brain injury experience agitated behaviors. Agitated behavior is going to be different depending on the person, so the presentation is going to change. But you might have physical aggression, you might have inappropriate speech, so slurs, racist comments. They might be restless, so they might need to get up, want to get up, always be moving, flailing their arms around. Mood lability, so they might go from being fearful or anxious to being really somnolent, tired, to being angry and aggressive. And the resolution of these symptoms can vary by person. It can take days to weeks, sometimes longer for these symptoms to kind of resolve, but it is part of the common symptoms of a traumatic brain injury. Most people who experience a traumatic brain injury experience something called post-traumatic amnesia, so PTA. And PTA, by definition, is confusion and lapses in memory regarding or surrounding an accident. And so if someone's confused, they can't recall where they are, why they're there, they're more likely to be things like aggressive or to be restless because they want to return to a routine. And so it's important to remember that a lot of what you might be experiencing or seeing when working with a patient is unintentional. It's more of a symptom rather than something they're doing on purpose. Neuropathology. Neuropathology is just a really fancy word for saying things in our brain that can change. And so we have structures in our brain. There's a nice blow-up brain outside for those who haven't seen it with a few different structures labeled. So we have lots of different lobes. And so when we have damage from a traumatic brain injury, we have lesions or a tumor from things like cancer, it's going to cause changes in the functionality of our brain. When there are changes in the functionality of our brain, it can lead to changes in behavior, changes in cognition, and changes in things like our mental health or psychiatric health. And so it's always important to recognize that this can cause agitation. And so, for example, let's say someone has an accident and they injure their frontal lobe. They might have more emotional lability, so more quickly to react to things, be more easily irritated or angered. They might have difficulties with their attention. It's harder for them to stay focused on one thing, and if they're not focused on one thing, it's going to impact their memory, their ability to organize their thoughts. If we have damage to our limbic system, that's going to have significant impacts on our mood and how quickly that can change and how well we're able to control it. And so our brain has lots of different parts that control different things, and so when considering what behaviors you're seeing in something like a traumatic brain injury or after an acute event, it might be important to see what's present in imaging because that might help explain some of this agitation that you're noticing. There are also changes in things called neurotransmitters. And so these are things that are present in all of us. We have serotonin, dopamine, GABA receptors, lots of different things. And if we have too much of one, let's say serotonin, some of you may be familiar with the term serotonin syndrome. It might lead to changes in awareness or changes in our cognition or alertness. And so it's important to note that these changes can be the result of many things. It could be the change of medication side effects, it could be the change of aging, it could be the change of a degenerative process in our brain, it could be the change of something like a traumatic brain injury. And so when trying to identify or look at causes for agitation, people who've had some changes in their neuropathology or changes in how their brain is working or their physical structure, they might be more likely to experience agitation or different types of aggression during something like an acute care stay. And there are some other risk factors we want to talk about. So age is an important risk factor. As people get older, they're more likely to experience changes due to many different things, cardiovascular risk factors, so things like heart disease, hypertension, normal aging. They might have the presence of other medical factors. And so age has been found to be a risk factor for developing agitation in an acute care setting. And so it's important to know if you have older patients, they might be experiencing agitation more frequently, and this could be due to medical conditions. This could be due to things such as changes in routine. Who here likes to have their routine interrupted? Nobody raised their hands. So I'm going to go with nobody. When a routine's interrupted, it can cause agitation, it can cause confusion, and this is especially true for older adults who might be experiencing changes in their thinking abilities already. So something like a dementia process that we'll talk about a little bit more later. Gender has also been found to be a risk factor. Just broadly speaking, male patients have been found to have higher levels of agitation and aggression during inpatient stays. We're talking about mental health history, so things like anxiety, depression, bipolar, schizophrenia. The presence of those, due to multiple different reasons, can have impacts on things like our neuropathology, so we could have different levels of serotonin and dopamine, which could put us more at risk. It could be the medications we're taking or someone's taking for that. It might put them more at risk. And it could also just be interactions with other people. If someone's very anxious, they might be more fearful of interacting with medical providers or have a trauma history. And so that might have impacts on care or levels of agitation. And the last is substance use history. So substance use history puts someone at an increased risk for those changes in their brain or makes them more susceptible to things like medication side effects, the result or mechanisms related to injury or disease or changes related to that. And so it's just nice to know background about our patients, but also consider these things when we're looking at agitation. All right, delirium is one of the most common diagnoses that's been found to be related to agitation. Delirium is an acute, so somewhere between hours to a little bit of a gradual progression over a few days, change of awareness, alertness, and thinking abilities. And so what this might look like is someone who has a delirium process might not be able to reliably engage with their environment. It might be harder for them to maintain attention on multiple things, so they might focus on one thing, or they might be able to focus on anything at all. They might have changes in their activity levels or experience something like delusions or hallucinations, so seeing, hearing things that aren't there. Oftentimes, what the cause of a delirium is medical, so it's found to be related to things like a traumatic brain injury, something like illness or illness or sickness. So if you have an infection, for example, sepsis while you're in an inpatient stay. Something like a neurodegenerative disorder, so an Alzheimer's disease, Parkinson's disease, all are more likely to experience something like a delirium. And then one of the more common ones I want to talk about or just mention is withdrawal from a substance. You know, when we see people in an acute setting, or when someone might be seen in an acute setting, they might have had a traumatic incident, they might not be much known about their history, and so it's just important to realize a patient might be withdrawing. If someone's withdrawing from a substance, they're more likely to experience things like agitation, anxiety, depression, physical symptoms as well, and so it's just important to kind of keep that consideration. The other thing I want to mention is one of the biggest causes of delirium in an acute setting is actually a UTI. I don't know if that surprises anybody, but it's something I wanted to mention. So managing the causal root of delirium, so treating something like a UTI, can help a delirium resolve. And there are different types of delirium. So there's hyperactive. Someone's going to be moving around. They might have hallucinations. They might be anxious and fearful. There's hypoactive. So someone's sleeping all the time, somnolent. They're withdrawing or reducing communication or interaction with others. And you might have a mix, so it might fluctuate between being very hyperactive, anxious, seeing things one moment, and then the next, you might be asleep. And so it's important to note that delirium can look like a lot of different things, but when we're looking at it, we're considering kind of that acute cause or that acute progression, changes in awareness, and then looking for a causal factor in the root behind it. Dementia. Dementia broadly is changes in an individual's thinking abilities that are significant enough that it impacts their ability to manage their day-to-day. So if someone has a dementia process and we're diagnosing them with that, it might have impacts on things like their ability to manage their medications, drive independently, manage their finances. And so if someone's having changes in their thinking abilities to that level, they're diagnosed with a dementia. There's lots of types of dementia. So there's Parkinson's, Alzheimer's, vascular-based dementia. The most common one seen is Alzheimer's disease. And when we think about Alzheimer's disease, we always think about changes in memory, changes in that kind of awareness of factors. And so if we're thinking about an acute care setting, if someone's having difficulties with their memory already and there are very significant changes in their routine, they're going from home to a hospital bed, they're more likely to be confused. If they're more confused, they're more likely to be something for agitated or have difficulties interacting with their environment reliably. And so dementia is one of those diagnoses that's more likely to cause someone to experience agitation during their stay. Serious mental illness, SMI. There's lots of different ones, but the most common ones we see are depression, schizophrenia, and bipolar. These diagnoses put you more at risk for experiencing agitation and interacting with care providers due to things like willingness to engage, paranoia. You might be experiencing something like delusions or hallucinations. Often this is related to a few different factors. The first being that there's changes in medications while you're inpatient. So there might be medication interactions with your antipsychotics, for example, if you have schizophrenia. Or let's say no one knows you have schizophrenia or bipolar or depression because you were brought in from an outside hospital or brought in due to an acute accident. You don't get your medications. You're likely to experience the symptoms that were well controlled before, and those symptoms might lead to paranoia, for example, or overall reduced interactions with care providers. once again, increasing the risk of agitation. And if patients are agitated, it's going to impact their care, it's going to impact their ability to engage in their overall care, engage with their providers, and their overall outcomes. And then the last one is comorbid substance use disorders. And so this occurs partly due to withdrawal. So if someone's withdrawing and they also have a serious mental illness, it might increase the factors that we talked about already. It might increase agitation, it might increase restlessness, might increase anxiety. It also might have impacts on medications being prescribed for that withdrawal, which could also have changes on how the body manages medications for things like antipsychotics or how medications interact. So this is a nice little chart that we found. And so on one side, we have a likely psychiatric etiology. And so when we look at this etiology, we're able to see that typically, and this isn't true for all patients, but this is just kind of what's commonly found, that if agitation is related to a psychiatric etiology, the patient is more likely to be oriented, alert, experience a gradual onset. Importantly, the psychiatric etiology, so have a psychiatric history. Their vital signs and physical exam are more likely to be normal. They're younger, and they might experience an auditory hallucination or flat affect. And also, and this is important, they're more likely to be redirectable. So they're more likely to follow commands, requests, answer questions with extra prompting, encouragement, validation, that sort of thing. Versus an organic etiology. And so an organic etiology might be something like a brain injury, it might be something like delirium or dementia that we talked about earlier. And so if someone's experiencing more of this organic etiology, they're more likely to be disoriented, have a depressed level of consciousness, and so this is more somnolent, less responsive to providers, to external stimuli, so voices, physical touch. It's more of a sudden onset, so it's more likely to happen very quickly. There's going to be abnormal physical and vital signs. They're typically going to be older. They're more likely to experience visual hallucinations, and they're not typically able to be redirected. And so something that's important to consider between these two is what they have in common. And so I'll give you all just a moment or so to consider what the psychiatric and an organic etiology of agitation have in common. All right. And so what they have in common is that someone who has, let's say, an organic and a psychiatric etiology, they're both experiencing changes in their ability to attend to the environment, to reliably engage with their environment, and in their thinking abilities. And so you're having changes in these abilities. We're thinking broadly changes in attention, changes in their ability to hear or see things that are adequately there or truly there, and in their ability to think quickly or in their memory, they're more likely to experience agitation. And so when we think about different kind of processes, different ways this could look, the main thing we're identifying is the declines in ability to attend and the changes to engage with their environment reliably. And then the last thing I want to talk about is early warning signs. And so there are many different early warning signs that can be found when interacting with patients. And it's really important to identify these because if we're able to identify these, we're more likely to be able to address them early, to manage them early, and if we catch them early or manage them early, they're less likely to escalate. If they're less likely to escalate, then there's going to be less need for increased interventions, so things like restraints, for example. And so I'm just going to pick a few of the more common ones that I've seen. And so some of the more common ones I've seen are the pressured speech, the angry outbursts, and then the changes in mood. So they might be very anxious, very somnolent. Experience those changes might be a good warning sign. They might get angry over, let's say, interacting with providers or for certain kinds of treatment. And so identifying, exploring those. And then just changes in their speech or their thinking abilities is another good indication. So are they experiencing fluctuating alertness or awareness? So sometimes they're able to follow along and track with you, other times they're not able to do so. Yeah, and now that we have a good idea of what the warning signs are, I want to talk about, or have Dr. Fullen here talk about, some de-escalation techniques.
What time is it? So we have 40 minutes. Okay. I am not going to be as good as Dr. Doherty as not looking at my slides. I feel like I have way less peripheral vision than I thought I did, because I'm like this to try to see what's on them. Hi, everybody. So let's go ahead and talk about best practices in agitation management. So I wanted to kind of start this by getting the opportunity to talk about some current research that we're reading about agitation management. And so the first part of the slide is actually taken from a comprehensive 2020 study, a qualitative study where nurses across the nation who work in acute care settings were asked, how do you manage agitation? What works best for your patients? And those nurses got together and very sort of unanimously said that non-pharmacological interventions were almost the sole thing that helped them manage agitation best for their patients. And in the past 60 years of research, that has kind of stood the test of time. Non-pharmacological interventions are our first line sort of treatments against agitation. So what that includes are things like verbal de-escalation, diversionary activities or redirection, environmental adaptation, so how we can adapt environments in a way that improves patients' experiences, and that those things are consistently implemented by all of the staff, techs, nurses, other treatment team members, allied health, everybody. So everybody is sort of consistently doing the same thing with an agitated patient. It also the study talked about things that you want to avoid when you have an agitated patient. And so as much as possible, trying to avoid any sort of treatment or intervention that could cause injury, cause trauma, or negatively impact the rapport that a provider and a patient could develop together. And so typically some of those things, although we have to use them, and I'll talk about this too, but any kind of chemical or physical restraint is really what they were referring to here. So essentially, this study aimed to say our goal should really be that we want to balance patient care while also prioritizing patient dignity. Even when a patient is agitated, we want them to be an active member making decisions about their health care. And so how do we kind of find a balance to do that? And so another really awesome study I wanted to talk about, 2016. It's so weird because 2016 is kind of like a long time ago already, but bear with me. So a 2016 study, they looked at a bunch of initial inpatient hospitalizations for people and found that across the board, about 53% of people, so a little bit more than half, coming into the hospital are actually experiencing some form of episodic agitation or significant distress that's requiring intervention from staff. And when they are experiencing that agitation, about 37%, so about a third of them, are experiencing multiple episodes. So it's very likely that many of these people fell in the categories that Dr. Doherty was describing: delirium, traumatic brain injury, maybe they had a neurodegenerative condition that was already going on that put them more at risk for the development of agitation. But more than 50%, that's a lot of patients, especially for the nurses and techs who are spending hours with patients who are agitated. So what they found that was using these first line de-escalation strategies, that they were successful in 60% of cases. That's a pretty good amount, 60%, I'll take it. And that if they were using de-escalation successfully with a patient who was agitated, that future episodes of agitation were less severe and occurred less frequently. Also pretty good. So let's talk about why de-escalation is important. So de-escalation essentially prioritizes patient and staff safety. That's huge. It decreases interruptions in care, like Dr. Doherty was saying. It reduces the need for physical or chemical restraint that can impact rapport and patient satisfaction, and it's repeatable. It is a teachable skill that anybody who's interacting with a patient can use. Without de-escalation, you have a complicated care picture. Now you have restraints. You have to monitor how long someone's in restraints in order to get them out to rehab. You have a ton more medications. No one wants to work with the patients because they're getting a bad reputation, frankly, for being agitated on the floor. Nurses are burnt out. They can't keep seeing the same agitated patient for 12-hour shifts. Is it 12-hour shifts? Can a nurse confirm someone? Yes. 12-hour shift, that's crazy. That's so long. I could never. And then you have this decreased patient satisfaction. You have a massive impact to patient outcomes. And unfortunately, one of the biggest things you end up with is prolonged hospitalization if you have an agitated patient that isn't responding to any of the sort of de-escalation techniques. So if you are in the audience and interested about agitation management, we would like to invite you to consider a couple of things. If you're working somewhere that doesn't already have annual trainings in agitation management, that is a must. Annual trainings in agitation management where you can certify someone and say, hey, now you're certified in agitation management, and maybe have kind of redos every 2 years so people can get recertified. That's important as well, so you can kind of keep all of your trainings up and current. Also, implementing an assessment model. If you have agitated patients, you need to find out how agitated they are and how well your interventions are working. So if you're seeing agitated patients, you want to be recording that and having a model for that so that you can see, are the things you're doing actually working and how well are they working? Also, an interdisciplinary approach. I have to pause for a second. I searched this PowerPoint for a typo, and I thought I didn't get one, and my worst fear is having a typo, and there's a typo. Someone needs to de-escalate me. Okay. Interdisciplinary. So using an interdisciplinary approach is super important, I think. We need everybody involved. I can't even tell you how, if I look out in the audience, there's so many people in here that work with me in acute care, in acute rehab settings, and every single one of them are my care members that help me with agitated patients. And I always draw on their expertise. It's our collective expertise that helps improve patient outcomes. And then last but not least, if you don't have a protocol for agitation management, you need one. There should always be a sort of drop-down flow chart that if people are doing or presenting in certain ways, you can refer to that so you can know uniformly how you're going to respond to those things. Because one of the most important things is consistency across staff. So when Dr. Doherty and I were making this slideshow, I was like, I feel like there's something that we have to say about the most important things. So I was like, well, what do we do? And so I was like, let's start there. So this is what we do. When we are told, hey, we have an agitated patient on the unit, we have an agitated patient in this room, go and see them. These are some of the first things that we're thinking about. So the first thing is accurate diagnosis of agitation. Make sure the person is actually agitated. Then notifying all staff that are interacting with that patient so everybody can get on board. Then working with the staff and the patient to whatever degree they're able to be able to really identify any triggers that could be preemptively causing the agitation. My best work days when I can figure out what's causing the agitation, we don't have to do any agitation management because we just treat that and then the agitation goes away. Consistent and repeated assessment. I have some fun ideas I'm going to share with you guys about how to do that. Implementing those best practices, and we'll go into that in detail as well. And then trying to reserve the most restrictive practices like chemical or physical restraint whenever possible. And the biggest one here is probably using trauma-informed care, making sure that your patient is the center of your healthcare system and everything works around that. We want to highlight patient dignity always and make sure that every single interaction we have with patients make them feel safe, make them feel respected, and that's always the goal. Okay, so to kind of go through those key principles one by one, I'm going to kind of share a little bit of our process So the first thing is diagnosing agitation and looking at some secondary conditions or those things that could be triggering agitation that you potentially treat to make the agitation go away. So how we do that is really go in and try to obtain a very comprehensive history. Want to figure out any other medical comorbidities that a patient could be struggling with and get an in-depth social history. Like Dr. Doherty said, substance abuse, mental health histories, these types of things put people at risk for the development of agitation far more than other things. We don't perform comprehensive physical exams, but our medical colleagues do, so we rely on them to let us know if anyone has anything going on physically that we need to know about. And then we use that information to see what could be contributing to this agitation that we could potentially minimize. So here's the big things. I'm going to touch on some of the things in more or less detail. Pain, it's huge. It can make people very, very, very cranky. Aphasia, this happened to me just the other day, where someone I was seeing was aphasic. They had an expressive aphasia, and they had no awareness that they had an expressive aphasia. So we were both talking about the same thing, but the patient didn't think that I was getting it because the patient thought that they were saying something completely different. And so what ended up happening is the patient became very, very upset, which makes sense. Miscommunication, not being able to communicate with the people that are coming into your room, touching your body, performing exams, trying to give you information that you might not fully understand, that can be really, really scary. And when people get scared, when people get scared, that can really cause a lot of distress, which can result in agitation. Another one I want to talk about here is the use of the bathroom. You have people after a traumatic injury that are given bedpans or put in diapers and said, hey, go in that. This is where you are. You got to go in that. Like, that is a complete removal of dignity. And while it might be necessary for their medical care at that time, it's really, really hard to convince a 36-year-old woman to use a bedpan or use a diaper because it just seems so completely random and obscure. And so people can get really upset about that. Sometimes people can really hold going to the bathroom too, which can cause a lot of pain, develop a lot of agitation, and then we have a consult. Another thing here is NPO and PO restrictions. So many people, especially after a brain injury, have a Dobhoff tube, and they'll tell me, I'm just so hungry, just give me something to eat, because they're not understanding that they sort of nutritionally are okay, they're still sort of having those hunger cues from the brain. And so it's really, really hard to kind of get them on the same page as you, but you need to do whatever you can to try, because if you can interfere here, treat, provide education, or even support, you may not need to worry about the agitation management part. So when you do get into a patient's room and you want to sort of really assess that agitation, the best practices tell us that we want to use standardized measures and objective measures. So we all should be able to go into the patient's room and get a very similar, hopefully the same, rating on how a patient is doing. But if we don't have something like this, I could go in, and because I see agitated patients every day of the week, I might be like, yeah, that person's okay. But maybe Dr. Doherty goes in and he's like, whoa, that person is really upset. They're really upset, right? So you need something objective and standardized across the board that you can use to really definitively say, yes, this patient is agitated, and they're mildly, moderately, or severely agitated. So the scale that we use most often is pictured on your screen. It's a little bit small, but it's called the Agitated Behavior Scale. There are others you can use. Some of the popular ones are the Brief Risk Assessment Tool and the Targeted Risk Assessment Tool. These are things that are really easy to use. Multiple healthcare professionals can use them, and the nice thing about them, you can do them repeatedly. So you can go in, determine if agitation is actually present and to what degree, and if you're doing this 3 times a day, you can figure out, hey, is this person always becoming agitated after lunch? Maybe they're always becoming agitated after, this happened to us actually, always becoming agitated after lunch because they're experiencing really bad indigestion, really bad tummy pain. And that's what's affecting their mood so much. And they can't tell us because they're brain injured and maybe they're aphasic, right? And it can also tell you how well your interventions are working. So if you're assessing someone repeatedly with something like an agitated behavior scale, you're able to see, okay, everyone's on board, everyone's using verbal de-escalation, everyone's made every effort to adapt the environment appropriately. Is it actually working? It will. And to what degree is it working? And it's important for you to have that information. So you'll also see that I noted here that measures of orientation can be helpful, and that's because most people who are experiencing significant agitation have a recent neurological insult, or they're delirious, or they have a dementia process going on and they're delirious. So you really want to make sure that you're also tracking if they're becoming oriented, if they're understanding where they are, why they're there, when it is. Because you'll see that as agitation decreases, orientation increases, and vice versa. So the more and the quicker we can get someone oriented, the less chance we have, the reduced chance we have of agitation. Okay. Let's get into it. I'm talking around it, we're gonna get into it. So the point of verbal de-escalation and valuable environmental management really is this. It's to interrupt emotional activation. And to do that by establishing a relationship with an agitated patient or person, agitated person, that will help provide that person the opportunity to regain control over their emotions. That's what it is. It's not to exert control over someone else and get them to do what you want, but to empower them to be able to take a better stance in their interaction with their environment. So, disclaimer, we know that this stuff is super simple sounding, but if you ask any person in this room when they deal with agitated patients, this stuff is not easy. And the reason why, the number one reason why, is because while you're trying to help someone else get back in control of their own emotions, you have to moderate your reactions. Because essentially, we're asking people to go into rooms where they could be cursed at, called horrible names, sworn at, dodging trays that people are throwing, right? Things that you would never condone outside of work. You would never let someone speak to you that way. So naturally, we're having to manage our own reactions while simultaneously helping someone else manage theirs. So that's a tough thing. So step one, verbal de-escalation. I feel like it's a misnomer. It should be like communication de-escalation, because one of the biggest parts and the most helpful parts of de-escalating someone who's agitated is your body language. Even people who are confused and disoriented, you got a 44-year-old man disoriented, just had a brain injury, very agitated, they have 44 years of experience in reading body language. So if you go in and you're tense or you're angry, they're gonna pick that up quicker than they pick up the things that you're saying. So always go in with a non-threatening stance. I can't tell you how many times I go into a room and I have a provider like leaning bodily over someone in a bed. Try to respect personal space. You're sort of interacting with a person who is getting vitals. They are getting labs. They are being cathed. They are being wiped when they go to the bathroom for the first time since they were 2 years old. And these types of things make people feel like they're not in charge of their own bodies anymore. So really respect personal space. Always, even if you think someone remembers, introduce yourself and reaffirm what your role is, why you're there. Make sure that you are querying their concerns, really getting into detail about what is upsetting them, what their concerns are, what's going on. Make sure that you slow your pace of speech and decrease your volume. A lot of times people do such a good job, but then someone starts yelling, so they start yelling, not because they're yelling, but because they want to be heard. That's never, ever gonna work. Always try, I swear it, you can whisper and someone will slowly stop and try to listen to you so they can figure out what you're saying. It's just instinctual. It's like a reflex. Make sure you speak in simple terms, and also make sure you're making supportive statements about what someone's telling you that they're feeling. Don't get caught in the trap of making supportive statements about someone's angry diatribe about another provider. Don't be like, yeah, that's not good. Try to rather be like, wow, I can tell that that's really frustrating for you. So not necessarily the content, but what their feelings are. Try to make supportive statements about that. Ask open-ended questions. You want to keep the conversation going and really kind of increase the length of your interaction when someone is agitated. You want to be empathetic, avoid judgment. And if you're doing all of those things, here are some additional things we want to invite you to consider. So first thing, if you're in there and you're saying all the right things and you're doing all the right things and a patient makes an offensive or threatening statement to you, remember this is a symptom. That's part of that sort of managing your own reactions, right? Try to ignore statements like that. I always give someone like a one-pass rule if I'm in a good mood. If I'm not, then it's different. But either way, at some point, you have to sort of stop them and say, hey, that's not appropriate. Don't speak to me that way, and then move on. Because if you have someone who is confused after a neurological insult, remember, this is the most likely person to be experiencing agitation. You need to help them relearn how to appropriately respond to their environment. So if we're just ignoring what they're doing and moving completely past it, or the worst thing, someone makes a vulgar statement and you kind of laugh it off, you're sort of reinforcing that those types of behaviors are okay. So it's completely appropriate when someone says something terribly rude, when someone makes a racist slur, when someone makes a sexual comment, to say, don't speak to me that way, and then move on. So just like we want to respect somebody else, we want to teach patients who are agitated to respect us in return. Never try to reason. Let me tell you why that's not appropriate. Because if they are agitated to that degree, they probably don't have the capabilities to reason along with you. It's just going to frustrate them and you. Always make sure you are noting any triggers that could be happening in the moment. Encourage eye contact. Validate patients' fears, validate their concerns, reduce physical touch. And if you have someone who has become physically aggressive before, always go in a room 2 at a time. Assign one person to speak and just have another person there in case you need it. And try not to, when you do have multiple providers in the room, try not to have a conversation around your patient, because that can be very agitating and very demeaning as well and belittling. And if your patient is already throwing hands, the time for verbal de-escalation has passed. And then, unfortunately, we have to move to chemical and physical restraint. It is unfortunate, but it will happen. But you can't try to tell someone, please calm down, when they're kicking and hitting. At that point, we need to move to protecting the patient, because they can get hurt, and also protecting staff, because they're your biggest asset. Okay. So when we spoke a little bit about verbal de-escalation, communication de-escalation, let's talk about environmental management. So if you have a patient who's agitated, or also invite you to consider, if you suspect that a patient has a high risk chance of developing agitation because of their health history, because of their recent injury, their age, substance use, whatever the case may be, you can start implementing some of these environmental adaptations earlier to decrease the chance of agitation, full-blown agitation happening. So there are 5 things here. What's the time? 12 minutes left. Oh my gosh. Okay. Number 1, limiting confusion. So you want to do things like prioritizing being able to reorient the patient, creating a good day and nighttime routine. You want to communicate clearly. You want to balance stimulation. So many times agitation happens with patients because they're in a hospital for a long period of time. Maybe they don't have a lot of family who are able to visit, and they get so bored. So you really want to balance their stimulation and their periods of rest. We have had so many patients who've been kind of stuck in the hospital a little bit, becoming really agitated, because imagine you're in a hospital room, no one's interacting with you, apart from coming and get your meals, get your labs, get your vitals here and there. But if you maybe throw a couple meal trays, yell a little, you got a whole bunch of people going in the room, right? You got a lot of attention. And so we unintentionally reinforce that kind of behavior. So many times this is so quickly resolved by putting that patient in a wheelchair, taking them down to the nurse's station, letting them hang out for a little while, maybe an hour or so, putting them back in the room when it's appropriate. I know it's not always appropriate, but that's a nice, easy fix for someone who's potentially just bored. You always want to make sure you're redirecting when needed. That's that relearning how to appropriately respond to the environment, and then prioritize safety. There's a lot of awesome things we can do nowadays. We have virtual sitters, we have in-person sitters that could potentially reduce the need for chemical or physical restraint. Okay, we don't have a lot of time, so I'm going to go quick. Like I said before, if you can figure out a trigger and you can treat that, then you are less likely to have to focus on things like communication de-escalation or environmental adaptions. There are a bunch of things that can trigger a patient that are patient-related. We kind of spoke about it before: incontinence, reduced autonomy, pre-existing conditions, and then a bunch of environmental environmental triggers too: overstimulation, interpersonal relationships. And if you cannot figure out what your patient's trigger is, it's probably you. So a couple of do's and don'ts. So do intervene early if you can. Like I said, those environmental adaptions are so helpful. Always offer your patient 2 options to try to increase their autonomy whenever you can. Summarize interactions. It helps people feel heard. Reflect back those feelings that you're hearing. Use the least restrictive environment and work as a team. Rely on each other's collaborative expertise. Don't get upset. Don't ever tell someone to calm down. If you think you've gotten a patient that went from 0 to 100, you'll have them go 100 to 1,000 if you tell them to calm down. Never box someone into a small space. Don't go 17 people into a room to check out the agitated patient so everyone can see. That's not good. Don't forget about your body language, and don't forget about your patient's body language. Your patient's starting to become super restless, they're pacing, they're wringing their hands, something's about to happen. So monitor that. What's it on? Okay, so I don't know how we ran out of time. That's me being silly. I knew we were going to run out of time. We don't prescribe medication because we're neuropsychologists, but we would be remiss to say that medications aren't helpful in the management of agitation. Our biggest thing that we always try to advocate for, especially for patients with neurological injury, is avoiding medications that are going to prolongly sedate, unintentionally sedate someone for a long period of time, because then it decreases the opportunity for them to reorient, to start relearning their environment, because they're just completely asleep. And when they wake up, they're agitated again. So it doesn't necessarily always help. Obviously, patients have families coming in, helping out. They can get super freaked out when agitation happens. Make sure to provide as much education as you can so family understands that agitation isn't necessarily a permanent thing, but a symptom of what they're experiencing. And also understand, we need to balance that sometimes your family members, while they can be really helpful at times, they can also be the agitating factor for your patients. So monitor that. If you have to kick out family, you got to kick out family. And then support your team. Like I was saying, I think we were talking about this earlier. We go in to manage agitation. We're with someone for 30 minutes, right, once a day. Again, thinking about your nurses and your techs, you're with your patients 24/7. You really want to make sure that they have the support they need. Know the signs of burnout, have good rotating schedules, prioritize and learn about EAP programs, and really just provide as much training and support as you can. Do we have time for scenarios? Okay, we're going to do one. Yeah, you do yours.
We'll just do a quick walkthrough. So in this scenario, we have a 65-year-old African-American male who was initially brought in following assault with loss of consciousness unknown. On admission, GCS-12, subdural hematoma found on CT, and multiple cracked ribs on full examination. So during his first few days of admission, the patient was paranoid with staff. He's throwing his tray in water and making verbally aggressive comments to staff and others. And so as his admission continued, he began to evidence increased psychomotor agitation, so waving his arms around, being restless, kept trying to get out of bed, and refusal to participate in treatment. So from memory, he didn't participate in SLP, OT, PT at all after the third day, and he was getting these prescribed daily. And then patient was initially restrained, following which there was increased agitation for a short period, and then a withdrawal of communication. So what would you all do first? I know we have very little time, so I'm going to call on her way over there.
Assess.
Thank you.
Go with that.
Is he still in restraints at this time, or is he out?
Yes, so he's still in restraints
Okay.
and not communicating.
All right. See if there's anything that I can do to make him comfortable while he's in restraints, introduce myself, and just kind of ask, what else can be done while acknowledging that I'm not the one who can let him out of the restraints, and just trying to see if I can get him to talk with me a little bit.
Awesome.
Yeah, that's great.
And you said something else earlier. You said assess. And so when you assessed, what happened?
And so when I assessed, the first thing we talked about when we looked at those slides Dr. Folan showed us was we do a chart review. And so on chart review, not just his current admission, looked at his retrospective admission notes from other admissions and his care through the care medical record system we used. Come to find out, he has chronic, undifferentiated schizophrenia that he's not being treated for. And so we could imagine that they might have some of these experiences. They might be paranoid. They might be withdrawing because they're hallucinating or they're not quite sure what exactly is real. And so for this specific patient, medications were prescribed. I don't even think I saw him till 2 days after medications were prescribed. Lo and behold, he's still kind of angry, but he's doing much better. He's participating in treatments. He's no longer agitated or aggressive. He's still kind of confused, which is fair. I mean, he did have an assault and head injury, but he's doing a lot better. And so this example is just to highlight knowing your patients. We won't always know everything about them. We won't know sometimes anything about them. And so it's just important to question what else might be going on. All right.
Let's just go to questions.
All right, questions. These are references, but I'll leave this up. Any questions for us? All right.
Okay, thank you.
Well, thank you, everyone.
Sorry,
What?
didn't get to do the.
Set your mic.
Didn't get to do the.
Okay, that was really good. De-escalation, everybody needs it, seems like. Definitely. And do have a couple announcements, or one announcement. We've been getting a lot of questions about the slide availability, so we will have it at our website, at our program website. It's kind of long, but we can definitely get you that exact link, but it's idhi.uams.edu/brain-injury-program. I'll say that one more time. It's kind of a mouthful, sorry. idhi.uams.edu/brain-injury-program. Okay? Kind of a word salad thing. Okay. You want more time? Okay. I'll do it one more time. Late in the afternoon, right? idhi.uams.edu/brain-injury-program. uams.edu/brain-injury-program. Okay? All right, thank you for your patience. Y'all are hanging tough. I know it's a long day, but we still got 2 more really good speakers coming up. So our next speaker, let's see. I don't even know where I need to start with Dr. Sam Atcherson. He is a mentor and educator in audiology. He's professor in the Department of Audiology and Speech Language Pathology, Department of Otolaryngology, Head and Neck Surgery. He's had a lifelong hearing loss. So, one of the things about this conference, we brought a lot of people that are walking the walk, and they're having to deal with it. I think of note, he has authored over 60 peer-reviewed articles, 50 non-refereed articles, 3 textbooks, and numerous book chapters. A great scholar. He's on the editorial board of the Journal of the American Academy of Audiology and is a distinguished scholar, fellow of the National Academies of Practice. So, I think you're going to really enjoy this. Dr. Sam Atcherson, come on up, and I got to hook him up, so it might be a little delayed. I'll click that off if you.
I'm an audiologist. So I was going to ask, can you hear me now? Okay, well, I really enjoy what I do, but as you might know or may not know from audiology, our scope of practice covers not just hearing, but balance as well. And so, in full disclosure, balance and vestibular stuff is fairly new to me within the last 3 to 5 years. That's not to say that I haven't learned things about it in graduate school, that I haven't encountered this with some of our patients that we see in the clinic. But by and large, balance and vestibular assessment and even some rehabilitation is slowly growing in our field. So do we have any physical therapists in the room? I love you all. I have mad respect for what you do. Audiologists are dabbling in some areas of rehabilitation, but it's you all that really do the work, and we're seeing that impact. What audiologists can do is assess and hopefully refer appropriately. So that's one thing I wanted to say. And the other thing is as Danny had mentioned, I do have lifelong hearing loss. I'm a cochlear implant user. So when questions come, I may need you to help me to understand if there's any questions that you may have. But I'm happy to address anything. Okay, that having been said, most of what I've been doing is teaching classes and doing some research. And when it comes to TBI and head injuries, I'm still learning. I may just be a couple steps ahead of some of you. So the 3 things that I want to discuss today are some anatomy and physiology as it's related to balance. So a little bit different than maybe what you covered today. Differentiate the symptoms between dizziness and vertigo, and identify some common vertigo and balance issues related to TBI. I think you might be surprised at some of the things that I've uncovered. So, general anatomy. I'm going to start with the outside, the outer ear. On the left-hand side, you see the pinna. That's the thing that you can see. Sound is funneled through. And then you get to the middle ear area, which is about here. It's an air-filled space. And when we think of ear infections, there's usually fluid in there, and that can cause some balance issues. When we get to the inner ear, we have an apparatus that has 5 different independent structures: the saccule, the utricle, and 3 semicircular canals. And we'll be spending some time on that. We call that the vestibular system. But when we think about balance, it's not just the vestibular system. There's other related systems that work together to give us this sense of equilibrium. So this is a little bit of a busy slide, but if we could just focus exclusively on the vestibular system, what other systems are related? As you can see here, and I'm trying to make sure that I'm talking into the microphone, we've got some inputs that are coming in from the vestibular system that work with the cerebellum, and that will help us with compensation for gravity. We've got the brainstem, the vestibular areas, and they communicate with different motor nuclei in the brainstem to coordinate with muscles of the eye, the neck, and the spinal cord. And these help us with gaze and balance. But we also have the thalamus and the cortex involved, and so when we think about perception, we've got that up here and our sense of orientation. All these things work together to give us this sense of balance and equilibrium. If something is off, we know it. And many of you have probably experienced this before. Maybe you had an ear infection and you felt a little off, and you get this pit in your stomach like you're going to throw up. What does that have to do with anything? Well, obviously a lot. And when we start thinking about head injuries and traumatic brain injuries, we start wondering what might be affected. It could be the vestibular system, it could be the cerebellum, it could be other areas. And sometimes it's none of those. Maybe it could be because you had an acute injury that has since resolved itself, but because of that event, you now have a psychological component that has added to a sense of fear of falling. Good. So when we talk about balance, what is it that we're doing? Our brain is constantly trying to figure out which way is up and where are we going. So when you're just sitting there and you're just standing, we're getting a sense of where gravity is. But when we're moving forward or backward or sideways, we need to know which direction that is. I had no idea what this was like until I took in someone from Rwanda who was profoundly deaf in both ears because of bacterial meningitis. His cochlea, his inner ear, his balance system was completely affected by that. He had never been swimming before, and he was 24 years old. How do you think he felt going underwater, where you had no sense of where the ground was? Gravity. Very, very confusing that he just decided on never putting my head back underwater again. But he was perfectly happy to splash us around. So with that, the vestibular system can help with things like acceleration forces. It can help us with keeping our eyes on target so that things are clear to us and not blurry. And it helps us to direct our neck and body. And what I mean by that is, if we're moving forward, we have muscles in our body that have an equal opposite reaction to keep us upright, so we don't just simply fall over. Now, there are different parts of the brain that are responsible for helping us with our sense of balance. The vestibular system was one of those things that we talked about. The proprioceptive system is where we get motor muscles and joints involved in helping. Proprioception can also be thought of as the sensors in the balls of your feet and the back of your legs, your buttocks, And as you shift and you move, you get input into the brain as well. And then finally, the visual system. It's not so much about visual acuity, but it's about getting a sense of where things are, your head in relation to other objects. So we try to think about balance as being a tripod, where you have 3 legs. You can certainly survive without one of those legs, but if you take a second leg out, now you're going to be really unstable. So whenever we have a deficit in more than one of these areas, this is where we have to learn how to compensate. Perhaps some vestibular rehabilitation may help as well to overcome some of these issues. Now, when we think about stimuli to the brain, internal stimuli is coming from our ears alone. It's like our heads have a gyroscope in it. But when it comes to external stimuli, whether it's visual stimuli or someone pushing on us or the movement of a car, we now rely on our visual system as well as our proprioceptive system. And then finally, you have your central nervous system, your brain, which integrates all of this information to give you that sense of equilibrium. And interestingly, it's believed about 2/3 of the information the brain needs is coming from the the vestibular system. There are 3 reflexes that I want to tell you a little bit about, and these are actually quite fascinating. The first one is the vestibulo-ocular reflex. So we're thinking about the communication and the connection between the ears and the eye. When there's an input, our heads move. Remember, we have that internal stimuli. We need our eyes to move in a particular direction. So for example, if I'm looking at one of you in the audience and I turn my head really quick, I have an input going into one ear. I need my eyes to be focused on someone in the audience, and my eyes need to go the equal and opposite direction. But something that can happen is if there is hypofunction, if there's a deficit in one of your vestibular systems compared to the other, we develop something called a nystagmus. And that nystagmus is basically saying that the brain does not have equal input between the 2 ears. Okay? So we're going to be talking a little bit about vestibulopathies in a little bit. And I promise you, I'll get this all to relate to head injuries and traumatic brain injuries in just a little bit. You can actually induce nystagmus as well. Some of you have probably played this game before. Baseball bat, put your head on it, spin around real fast, and then run somewhere. Not so fun. You spun the fluid inside of your vestibular systems, and so you created a sense of disillusion in your brain, if you will. And so you become off balance for just a little bit. But if you were to do that to someone and stop their head and look, you'll see that their eyes start beating until the fluid stops. So that was the VOR. The vestibulospinal reflex and the vestibulocholic reflex involve the muscles of your neck and the muscles of your spinal cord, your trunk, and your legs. What the vestibulospinal reflex is doing is helping to keep your trunk upright, whereas your vestibulocholic reflex is trying to keep your neck upright. And if it helps you a little bit, does anyone here own chickens? Are you afraid to admit? Thank you for sharing. Well, do you hold your chickens? And do you kind of lift them up and down? What happens to their head? It stays straight. That's actually the vestibulocholic reflex working really, really well. We have the same behavior, but not quite that well. The vestibulospinal reflex, a good analogy is, has anyone ever held their cat upside down and let go? They right themselves. we are doing essentially the same thing, but in different ways. Our muscles are responding to the inputs that are coming in internally, externally, and being integrated within the central nervous system. So, when you see weird things happening where the patient has had injuries, it might not be the muscles that are the problem, it might be the integration that's happening within the central nervous system. Or it could be the vestibular system that's off. So there's some kind of communication disconnect. Okay, as we dive in a little bit further, many of you might know that the cochlea, which is the hearing part of the inner ear, has hair cells. And those hair cells respond to stimuli in the air. So air molecules hit your eardrum, eventually it makes its way into the cochlea, and voila, you can hear something. Well, the vestibular system also has those same hair cells, but they are arranged and organized differently, and they respond to different inputs, as we've talked about before, gravity, acceleration. One thing that you may not know is that these two structures here in green, the saccule and the utricle, have a layer of otoconia. And what otoconia are bicarbonate crystals. They sit on top of this gelatin substance, and as we move, it creates sort of a lag time with the hair cells. When we think about head injuries, the otoconia can be broken loose and end up in the semicircular canals where they're not supposed to be. And this is actually a common problem among people that have had head injuries. So we've got the utricle as one example, and here's the macular structure that has otoconia. The otoconia can break loose and end up either in the semicircular canal directly, which would be considered canalithiasis as a disorder, or the otoconia end up in the sensory structures where the hair cells are, and that would be called cupulolithiasis. So we'll talk about what that condition actually is called in just a little bit. So there, under magnification, are the rocks. We indeed have rocks in our head, but we want them to be in the proper location. Okay, and then we kept talking about the VOR, the vestibulo-ocular reflex. It is these muscles of the eye. There's 3 pairs or 6 muscles, and they help with lateral medial movements, superior inferior movements, and rotary movements. And all of these are necessary for far vision, close vision, left, right, up, down, so on and so forth. So when the VOR works correctly and we move our heads, the VOR should respond in an equal and opposite manner. And ideally, both vestibular systems are working equally. Another thing that you may not realize is, from audiology's perspective, there are several different tests that we can do. And we do this under goggles, infrared light, but we can look at behavioral patterns such as pendular or smooth pursuit. This is one's ability to just simply track an object. We've got saccadic pursuit, and that's the ability to jump, okay? And then finally, you have optokinetic. This one's kind of a weird one, but if you saw a bunch of lines just moving across the screen, involuntarily, your eyes will try to follow the bars, okay? So when an audiologist does their assessment and they see deficits, we can separate those into central nervous system disorders or vestibular system disorders. And we'll talk about this slide again in just a little bit. Corrective saccades are interesting. This is a normal thing that we would expect. Whenever our eyes get off target, it automatically wants to shift back. Okay? And it is the cerebellum that's actually trying to help us with that. I'm so used to having a laptop right here. That's why I keep coming back. All right, back to the nystagmus. What a nystagmus is a movement of the eye where you try to keep things on a target. And actually, I had to read up that the prefix nystagmo is actually derived from a behavior after drinking too much wine and people's heads slowly roll back and snap back up. And then somehow they applied that to the eye. So, if you were to look at someone who does not have nystagmus, you certainly wouldn't expect for there to be any kind of jerking movements and snapping back nystagmus. There are congenital disorders where there's chronic congenital nystagmus, and that may mean nothing at all. It's completely benign. But keep this in mind as we start talking about some of the different disorders that we might encounter. All right, symptoms of vertigo and dizziness. I've only got 2 slides for this section, and then we'll get right into disorders as it relates to TBI. So what is dizziness? Dizziness is a feeling of being lightheaded, unsteady, and you may faint. Many of us have felt dizzy before. It is not a pleasant feeling. For many of us, it subsides pretty quickly. But what if you had chronic dizziness? That is not something that anyone would want to live with. So I can't understand for the life of me as an audiologist why people would deny having a hearing loss. Oh, they're just mumbling. But when you're dizzy, you want help. Why is that? That's fascinating. That's something interesting about the human condition. Sometimes the feeling is mild and can go away, and other times it can be severe and come along with other symptoms such as headaches and throwing up. So dizziness is a symptom of an underlying problem. But what about vertigo? Vertigo is a hallucination of external rotation or movement. When people come to you and they say, oh, I'm feeling like I've got vertigo, most of the time they're really describing just dizziness and unsteadiness. If you have vertigo, it is literally this hallucination that the room is spinning. It almost seems like it's external to you. That is also not pleasant. Vertigo can be caused by many things, including vestibular problems, but it can be caused by many different health conditions. I do not have the expertise to be able to describe all of those possibilities. So with that, let's talk about some common vestibular and balance issues related to TBI. Since we're talking about imbalance and disequilibrium, it probably doesn't surprise you that falls are a big issue. It's an epidemic. So it is a leading cause of TBI and fractures. And when I say fractures, I'm saying fractures of the temporal bone where the inner ear is. Although there can be many other fractures, arms, legs, hips, so on and so forth. And it also shouldn't surprise you that as we get older, our risk of falls go up. So here are just some statistics that you may or may not be aware of. Falls are the leading cause of accidental deaths in adults 65 years and up. It's the 6th leading cause of death for the elderly. 60% of fall-related deaths occur in 75 plus years. 20% of people who sustain a hip fracture will die within a year. Of those, 20% will require placement within long-term care facility. 49% of those who sustain a hip fracture will die within 6 months. And falls among older persons accounted for almost 3 million emergencies. That's crazy. I wanted to share this not because we don't already know that this is an issue, but it is something that is highly preventable. Has anyone here ever heard of a matter of balance? We actually have this program in Arkansas, and there's a program being operated by the Institute on Aging at UAMS. So if anyone's interested, you should contact someone from the Institute on Aging and get some information about how to enroll some of these older adults in this A Matter of Balance class. And what it will do is to help those individuals, whether they've had a fall or not, make better decisions about not falling. Something as simple as being aware of what your feet are doing. We've all done this. Oh, I'm going to go this way. Your body goes, but your feet haven't gone with you. And you end up falling. But the other reason that you might want to consider this program is because after people have fallen, there's a lot of anxiety around falling again. And so now you have individuals that become really sedentary, and that exacerbates other problems. So we want to get people up, active as much as possible in the safest way. So 85% of vertigo and balance dysfunction may be inner ear related, could be a simple mismatch of neural firing rates between the two vestibular systems. So for some of these individuals, their falls are caused by the vestibular system having a communication breakdown in the central nervous system. As we talk about dizziness, dizziness is the #1 complaint in persons over 70. 50% of them will experience BPPV. Well, what is that? Benign positional paroxysmal vertigo. It is the long way of saying those ear rocks that I was talking about have gotten loose, and they're now in the semicircular canals. So BPPV has to do with those otoconia. Now, something I should tell you about BPPV. We all shed skin. We see evidence of it everywhere. We dust our homes. Well, guess what? Our vestibular systems shed otoconia. And if the body doesn't reabsorb that and gets rid of it, or the rate of reabsorption into the body is slower than you would expect, we have older adults who have too much otoconia where it's not supposed to be, that it ends up forming a piston inside of the semicircular canal. And now they feel off balance all the time. And the more they feel that way, the more likely they're going to fall. If they fall, they run the risk of a head injury. You seeing the connection here? Okay. Now, older adults with BPPV have greater incidence of depression, higher likelihood of anxiety, 3 times likelihood of falls, and reduced activities of daily living. But consider this as well, and you all know this, I'm preaching to the choir. We've got issues with polypharmacology, blood pressure, hypo or hyperglycemia, heart problems, lung problems, and peripheral atrial issues, and probably neuropathies of the legs. A few more interesting things. We can talk about falls all day long. We can talk about getting older all day long. But what about this? Vertigo is common for those who have experienced blunt trauma to the head, neck, and cranial cervical junctions. Motor vehicle accidents, falls, assault, and contact sports may cause vertigo. There's going to be great variability among patients. Not everyone's going to have the same structures that are affected. And the most common pathological condition associated with head trauma is, in fact, BPPV. 28% of individuals with head trauma are expected to have that. I'm going to take a slight detour, and I'm really mad at myself. I came across the 2019 paper, and it never made it into my presentation. But what I want to say is this. We can talk all day long about patients who have had a head injury, and we are now seeing them days or months after it has happened. But what is happening to patients who are in the acute phase? Okay, so within the first 2 to 3 days after the head injury, what are they complaining about? So there was a paper by Marcus et al. In 2019. They said that TBI is the most common cause of disability in patients under 40 years of age. Dizziness affects 50% of those patients at 5 years post event. And 25 of those cases of TBI are considered cryptogenic, meaning they can't identify what exactly is going on that's causing their dizziness. And that actually complicates any kind of therapy that they might do. Taking that a step further, this is also what's interesting from that paper. In the acute stage, they assessed 111 different patients from the time that they had their event, and they were still within that 2 to 3 day period. 87% of them complained about subjective dizziness. 58% of them complained about feeling imbalanced. 50% of them had headaches, and 40% of them described dizziness. Of those 111, they took 47 of those, and those reported the following. 62% that they had a gait ataxia, meaning their gait, the way that they walk, was affected. It was different than it was prior to the event. 38% had BPPV, and 19% of them had unilateral vestibular disorder. That's interesting. Okay, so first thing I want to talk about here with respect to disorders is vestibulopathy. What is this? This is a deficit or a hypofunction of one or both vestibular systems. If we were to talk about unilateral vestibulopathy, let's start with normal. You have spontaneous neural firing in both vestibular systems that's being sent to the brain. Okay? If I were to turn my head to the right, my right vestibular system increases its firing rate, whereas my left decreases its firing rate. And then I can do the opposite. But here's what happens with vestibulopathy if it's only affecting one ear. I've got spontaneous firing in one ear and nothing in the other ear. My brain is confused. My brain thinks that my head's turning right, but it's really not. This can happen within the first 2 to 3 days after a head injury. If you have any kind of unilateral vestibular insult, your brain will think that it's moving. that's actually quite terrifying to the brain, that something else interesting happens, whether it's unilateral or bilateral. When you're not getting the right signal to your brain in that acute phase, there's something called cerebellar clamping. And what this means is the brain is actually reducing the VOR, the vestibular ocular reflex. That's basically saying, I know something's going on, so I want you to just chill. Don't move your head, don't move your body, and things will be okay. When the brain realizes that the threat is no longer there, the cerebellar clamping starts to let go again. So what you end up having happen is that you have people with chronic unilateral vestibular disorder who think everything is just fine. I'm good. I can walk around. I can get about my day until one of two things happens. One is somebody turned the lights off in the room. Now you've taken your visual system out. Or your walking surface becomes unsteady. Carpeting, bumpy surfaces, grass, so on and so forth. Okay? When we have a vestibulopathy and there's mixed signals going to the brain, we can develop blurred vision, oscillopsia. With the vestibular system and its connection to the central nervous system, we do have vestibular nuclei in the brainstem. We can't fix vestibulopathy, but the brain can learn to compensate for that. So there's something called central compensation. Now, even if the brain compensated, it may not be the best situation for that patient. What they really need is vestibular rehabilitation. They need to challenge themselves in very difficult situations with respect to their balance. And it can be a graduated process. The physical therapists who deal with vestibular disorders know what I'm talking about. We certainly don't put them in the most challenging task right away. We gradually build them up to that situation. What's actually happening during vestibular rehabilitation is that you have to show your brain what is challenging to you. In other words, you have to make your patient do the things that they're most scared of when it comes to balance. You are going to induce dizziness. You're going to induce vertigo by having them do exercises to try to overcome that. And the brain can learn to adapt. So even though there's no change in the firing rate from one or both vestibular systems, the brain can learn to manage that. And that will become the new normal. So there's lots of different research that's happening that's way beyond my expertise, but I'm fascinated by the fact that we're not trying to fix the vestibular system. We're trying to help the brain compensate. So those of you that are interested in this area, pay attention to what's happening. I showed you this slide earlier already, but now that we've talked about the extraocular muscles and some of the vestibular rehabilitation activities that one can do, if you have a report back from an audiologist that there's deficits in pendular and saccadic pursuit, then it says here, if there are disorders here, they can be CNS indicators. So we need to help the brain compensate. And if you have a deficit with optokinetic pursuit, it could be vestibular or CNS. A little bit of a busy slide, but there's a difference when we're talking about nystagmus that comes from a vestibular problem versus nystagmus that's coming from a central nervous system problem. With vestibular disorders, there are predictable patterns where the nystagmus moves towards the healthy ear, for example. But with central nervous system nystagmus, you're much more likely to see up-down nystagmus, rotary nystagmus, and direction-changing nystagmus for no reason whatsoever. You could be looking at your patient's eyes and it's beating right. After about a minute, it starts beating left. What in the world is causing that? That's not a vestibular disorder. There's something else going on with the central nervous system. So here, I did attend a workshop down in Florida. So we have the American Institute of Balance. This is a fantastic center that has audiologists, PTs, and OTs on their staff. But they divide the patterns between peripheral nystagmus and central. So these are largely going to be vestibular, and these are largely going to be central nervous system. But that doesn't mean that someone with a central nervous system disorder and nystagmus can't later develop a peripheral vestibular problem too. And that just complicates things a little bit more. Okay. As we start to wrap up a little bit, what are some of the other inciting events related to trauma that we might see play out as a vestibular problem or even a balance problem? Lots of different things here. The things in red are the things that I want to talk a little bit more about. If anything else on this slide is of interest to you, we could talk about this during the Q&A or after my session. So again, BPPV, the pathophysiology is otoconia is dislocated to the semicircular canals. What's interesting about this is BPPV is not vestibulopathy. This is not a neural firing problem. This is the otoconia, the rocks, have gotten loose and have ended up where it's not supposed to be. So what this does is it causes sensitivity to any gravitational or inertial changes. So let's just say you had a head injury, and now you're starting to feel a little bit floaty. When you decide to go to bed that night, you sit down and you lay down, and now all of a sudden you're dizzy and you feel your eyes moving, and then it settles down. Well, that was interesting. I'm just going to go to sleep and it's all going to go away. Then you wake up in the morning, it starts beating again. And then it settles down. What in the world is going on? Well, again, those otoconia are moving through the semicircular canals. And your semicircular canals are connected with your vestibulo-ocular reflex. So that's a really telltale sign that you might have BPPV. It will usually fatigue after about 30 seconds. If you repeat the activity, you might not get it again at all until you shift in a completely different position. Okay? Now, this is easily treatable, but if it's untreated, your fall risk goes up threefold. So I'm trying to make the connection for us all that if there is a head injury, a TBI, we already realize that there's a prevalence of having BPPV. Maybe we should look into that. BPPV may trouble patients for years with periods of remission and exacerbation, It may last weeks to months with spontaneous recovery. It typically about 25% have a spontaneous recovery, and BPPV may have a relationship with diabetes, migraine, cardiovascular, vitamin D3 deficiency. What is the treatment? The treatment is, there's lots of different approaches, and it really depends on which canal is affected, which semicircular canal is affected. But these are repositioning maneuvers. Based on your test results, you might be able to conclude, oh, the otoconia is in your posterior canal. If I know where the posterior canal is, I need to get the rocks back into the utricle, where it can hopefully be reabsorbed by the body. If it's in the superior canal, what in the world did you do to yourself? Because that's a very difficult canal to get rocks into, but it's possible. And then there's the horizontal canal. So these are absolutely fascinating to watch and to see right before your eyes in a matter of minutes, making a lot of these symptoms go away. For most patients that have BPPV, you can treat them in 3 sessions. And it's really unfortunate that a lot of health professionals out there aren't even looking at this. They're not even considering that perhaps there's otoconia in the wrong place. Okay, semicircular canal dehiscence, particularly in the superior canal. There's something interesting about our anatomy. The superior canal shares the same bone as our cranial cavity. And for some patients, for whatever reason, that bone is very thin, and it just takes the right event to cause that to break. And what you end up with is a third window. So superior canal dehiscence is sometimes called a third window disorder. It can happen through injury to the head. It can also happen for some people where they blow their nose too hard. So that increased intracranial pressure is causing that thin bone to give away. So what do these patients complain about? They complain about things like this. I'm chewing ice, and my eyes are moving while I'm chewing. I love Doritos, but I don't eat them anymore because I just feel this vibration in my head. This disorder is so fascinating that if I take a bone oscillator, which is something we use for hearing assessments, I put it behind your ear, you can hear it. If I put it on your elbow, you can't hear it. But for someone with superior canal dehiscence, they can hear it on their elbow. So they are receptive to any vibrations in their body because of that extra window. So you'd have to do this through CT scan, and it is correctable, but it's in a pretty difficult, challenging area to repair. And so ENTs that are involved in this kind of surgery, they want to know the extent of how big that third window is. If it's large, let's try to treat it. If it doesn't affect your life terribly, maybe we just don't do anything right now. So again, CT scans, and so the superior semicircular canal literally runs right up near the intracranial cavity. From an audiology test, we have frequencies here, low frequencies to high, and the loudness of sound goes down. So up here, this would be considered normal hearing. Down here would be a severe to profound hearing loss. What's interesting about superior canal dehiscence is that the blue and red lines are what you hear through your ears, through air conduction. When we place a bone oscillator behind the ear and vibrate your skull, the thresholds in normal hearing individuals will match the air conduction thresholds. But because of that increased vibrational sensitivity, we can pick that up on an audiogram. And then down here, 2 of the tests that we can do are vestibular evoked myogenic potentials. These are muscle responses. And weirdly, someone discovered that if I present a loud enough sound to the ear, I can get the saccule and the utricle to respond to that loud sound. And when you get those loud sounds in there and the muscles respond, that's not really a normal thing. The threshold for the muscle response is much lower than it is for someone with no superior canal dehiscence. Persistent postural perceptual dizziness is an interesting thing here. The pathophysiology is not well understood, but it does typically follow vestibular insult, a medical event, and acute psychological distress. And so what happens is any change in posture, motion of self, or visually demanding environments can provoke symptoms of dizziness, unsteadiness, and non-room spinning vertigo. This is fascinating to me because in the event of, say, a head injury, a TBI, perhaps you have a vestibular insult. Perhaps the event alone caused enough anxiety, you end up with this chronic, persistent issue. These patients are going to need help with this. So the 5 criteria to diagnose this would be non-room spinning, unsteadiness, and difficulties with balance. And it must be present for most days over a 90-day period. There should have been the word day there. Symptoms cannot be provoked but be exacerbated by changes in position and exposure to certain stimuli. It must be preceded by a condition with acute, episodic, or chronic vestibular symptoms, and patients with this disorder must be troubled by those symptoms and have impairment to some degree. And finally, it cannot be explained by any other medical condition or disorder. Something to be aware of. And this is the very last thing. It doesn't specifically address head injuries or TBI, but I think there might be an interesting connection that we might want to pay attention to. And that is, they looked at the association between saccule and semicircular canal impairments and cognitive performance among vestibular patients. So just real quickly, 54 patients presenting to Johns Hopkins were in the study. There was a good split between male and female. Average age was 55. They did one of the vestibular evoked myogenic potential tests. Among 40 patients with the VIM test, 31, 14, 55 of these patients had bilaterally present, unilaterally absent, and bilaterally absent VIMP responses. In caloric testing, and what caloric testing is looking at is, it's such an interesting assessment. But you're looking at the horizontal semicircular canals. You orient your patient upright, you put cold air in, followed by warm air. The cold air condenses the fluid and causes it to drop down. It causes your eyes to move in one direction. Then you heat it up, the fluid expands, rises, and causes your eyes to move in the opposite direction. Fascinating. And what we have here is among 43 patients with caloric irrigation testing, 55, 32, and 11%, normal semicircular canal function, unilateral impairment, and bilateral impairment. So what they did was they took these individuals and put them through a cognitive assessment. And I am not familiar with these assessments, but the two that they did were the Benton Visual Reinforcement Test and then the Trail Marking Test. And those with vestibular disorders had a significantly higher number of errors on the Benton test. And then down here, when they compared these patients to case controls, they noted that they had poorer cognitive performance. So I thought, wow, untreated vestibular disorders might also be impacting our cognition. So all that to say, perhaps we should be paying a little bit more attention. We are aware head injuries, TBIs, can cause a whole host of problems, but it never really occurred to me that maybe we've got some vestibulopathies going on. We are knocking otoconia loose, and both of those may be addressed in a good percentage of patients. Thank you very much. Any questions that I can address?
Yes. How about if you're 90-year-old and you've been forward head posture stooped for the last 20 years, probably. And if you try to correct the posture to head up, loses balance. It's really challenging to treat a patient like that.
You said a 9-year-old?
90.
90, oh gosh.
So you let the patient always falls, but what triggers it? If you try to even just, facilitate one type of patient to just do this, man, he was off balance. So you have to really rehabilitate that patient at this is normal.
Is the patient normally just hunched over? Yeah. I think that when we are in a certain position for a long period of time, any shift, and you've not given your brain time to adjust to that new position, you're setting yourself up for failure.
Correct. That's what happens to these
Right.
patients in that population. They have these chronic falls because maybe any kind of turning position,
Mm-hmm.
or somebody tried to tell them, hey, look up straight. That's what we tend to do. Tell people to stand up straight.
Absolutely.
This makes it worse.
Absolutely, it can make it worse. Yep. Anything else? Yes.
What would be a place locally where a person could get these tests done to see what's going on?
I don't have the answer to that. I would like to know myself. You're talking about a cognitive test or a balanced assessment?
Why you're having intermittent nystagmus and
Okay.
dizziness and loss of hearing?
Generally, any ENT clinic will probably have audiology staff there. So UAMS has an audiology clinic.
And if they told you there's nothing wrong with your ear, then what do?
If there's nothing wrong with their ear, then you probably have to suspect a CNS problem, and then that would be probably neurology.
Okay.
Mm-hmm. Anything else? All right, thank you so much.
All right, here we go. Okay, guys, I've got one announcement. We're going to have this on the last slide before y'all go, but I just wanted to, we do have a date set for Symposium 2025. It'll be September the 19th. We don't have a contract yet. I'd have to kill you if I told you. It's a secret, but it'll be local in Central Arkansas, I can tell you that. So we're excited. Hopefully a lot of you guys will come back if you like this symposium. All right, so we're going to go ahead and move on. So Dr. Mandy Yelvington, I need to make a little comment here. I think she has presented a couple of times, and we always put her either the last or near the last, and she is like a trooper, you know? I mean, it's just really hard to do these in the late afternoon. It really is. Us early folks, we get it done, we get to relax, and then people got, I got to talk, hovering over your head the whole day. But she's always been a really good trooper, and we really appreciate her. Mandy Yelvington, Dr. Mandy Yelvington, she's an occupational therapist. She works at Arkansas Children's. She is our burn expert, for sure, that we go to. Certified burn therapist. For the last 25 years, she's been practicing at Arkansas Children's and specializing in burn rehabilitation. So give Dr. Yelvington a nice, warm welcome.
Thanks, Patty.
To the right goes forward.
So the good news for you guys is one more and we're done, right? I'll preface this by saying congratulations to those of you who stayed. I know a lot of people see burn and they head for the door, right? So 25 years ago, I was coming out of OT school and I had two goals in mind. I did not want to do hand therapy because I was told that was horrible, and I didn't want to work in the burn unit. Guess what I do today? So good news about this lecture are there's some really cute pictures of our kiddos from burn camp, so you guys enjoy our smiling faces from this summer. I have no disclosures to report other than the fact that today I don't want to teach you how to be a burn therapist. I don't want to teach you about burn. What I want to talk to you about is what do we know in current burn literature that you can take home with you and use in your practice. So what do my patients have in common with people that you see on a daily basis? People who go through trauma often have scars, right? So we're going to spend a lot of our time today talking about scars and what we need to know about those, what the research tells us, and how we as therapists can make them better. So our goals are we are going to talk about this in the framework of a burn survivor. So what are the roadblocks for burn survivors? We're going to talk about this word cutaneokinematics, and that's one of my favorite new words. So we're going to talk about that. And we're going to talk about potential complications of burn scar contracture, but you can also think about that in terms of any sort of contracture or scar that you work with. So just to put this in a framework, what is a burn injury? So we think about a burn as being an injury to the skin. Now this can be caused by heat, it can be caused by radiation, it can be caused by friction. You have a patient that's in a traumatic automobile accident, has a big road rash, right? That is a burn, that's a friction burn. According to the World Health Organization, these can be caused by heat, chemical contact, a myriad of things can put these people in our field, in our realm to work with. As far as burns, non-fatal burns are one of the leading causes of injury that we see. There are about 500,000 burn injuries that happen in the US each year. 40,000 of those are seen and treated in hospitals. Percentage-wise, about 3/4 of those are adults. I don't know how many of you guys know, but the Burn Center at Children's is one of the only places that sees adult and pediatric burns within the state. We're the only burn center in the state, and we treat patients of all ages. Burns have quite a bit of cost in the healthcare market, averages about $88,000 per patient for their acute hospital stay with burns, and that obviously can be a lot smaller or a lot larger depending on their size. And we estimate that it's about a day to a day and a half in the hospital for every percentage of burn. So someone who has a 50% burn injury is going to be with us 50 to 75 days. So you can see that is automatically a long process for healing, and that's acute care time. So just to talk so that everybody's on the same page about what a burn is. So how many people have had a superficial burn injury? What's another name for that? Ow, yeah, it is ow, yeah. I mean, you guys can look at my tan and tell that I've never had a superficial burn injury, right? So a sunburn, it's itchy, it's tight, about a week it's healed, right? We don't worry about it, that's fine. A partial thickness burn injury is a little bit different. So that's maybe your, okay, the story we hear the most often, we're in Arkansas. What did you do? Well, I went to the Buffalo, and I might have had a beer. And I kind of passed out in my canoe. And I kind of woke up 6 hours later, and my back was a blister, right? So that is a little bit deeper injury. That tends to be your partial thickness injury that burns partially through your dermal layer, right? Deeper injuries even still, we get into a full thickness burn injury, which burns through the full layer of your dermal layer. The other thing you guys will hear us talk about when we talk about burns is what is our burn percentage, right? And that's not something you guys have to know and learn, but just so that everybody's aware, this map here on the side is our TBSA map. So you can kind of see, it's really little, but if you look it up, like each percentage of the body is divided up into some dividend of 9%. And so that gives us a number really important for fluid resuscitation, for knowing how long they're going to be in the hospital, and for predicting rehab times. Things to think about as far as types of burn injury for us are healing times. So healing times directly impact scars. So if somebody has a superficial burn injury, that's going to heal in about a week, right? How long does it take your sunburn to heal? You know, a week or so, it's fine, you're back in the pool. A superficial partial thickness burn, so a partial thickness burn that it's kind of light to the surface. It probably blisters. It's still going to heal in 7 to 20 days. Your deeper injuries that get deeper into that dermal layer are where we start to have problems. So we say anything that takes more than 21 days to heal is at high risk for scar. Right? So start to think about some of your patients that have massive traumas. Are their wounds healed in 21 days? A lot of times they're not, right? So that's when we should start thinking about scar formation. And anybody that has a full thickness burn, just go ahead and check the box, they're gonna scar, right? A full thickness injury. So what does skin do? What did we learn in A&P that our skin's for? Why do we even have skin? I'll tell you guys, when I do this lecture to the students, I always say, look, it's written right there. It's a cheat sheet, right? So skin is elastic, right? It stretches. Skin regulates our body temperature, right? It helps with homeostasis. It provides a barrier to the outside environment. It is the first thing you see when you meet somebody, right? You're looking at their skin. What about skin that's been injured? What about skin that's been burned? So this is really easy if anybody ever asks you what happens to burned skin. Think about all the things that skin's supposed to do. It doesn't, right? So it's no longer stretchy. It's no longer elastic. They can't thermoregulate, so the burn unit's typically very, very warm. They're more susceptible to infections, sensitive to sunlight. They can be hyper or hyposensitive, and it impacts their cosmetic function, right? They look different, they feel different, they act different. So let's start talking about research. What does research tell us about burn injuries? Because I am a research nerd, and I am fascinated by all of these numbers. So who would question that first stat? The bigger burn, the worse outcomes. Makes sense, right? But in research, we have to have it documented. So we have proof that that's true. Bigger burns have more risk of contracture formation, right? Worse in health outcomes, more contractures. And we know that if these scars develop, they significantly impact recovery because they reduce how much your joints can move. Now you guys look at our friend in this picture right here. What kind of movement do you think this kiddo has? Right? Not very much. And he's little, he still has to grow. So my friend Zach over there is going to help me out with a video. So what does skin do? So in order to move, tissue recruitment has to happen. So let's see what a normal piece of skin can do for us. So what is that skin doing? It's stretching, right? So non-burned skin, non-injured skin is extensible up to 50% of its length, right? So what does that mean? So for our therapist in the room, somebody tell me what this is. Nope, not TheraBand. This is non-burned skin. So I actually got my ruler and tested the extensibility of this, you guys. This has the same elasticity as skin that has not been burned, right? It's pretty stretchy. So imagine laying this over a joint. Can't do it to myself, right? It stretches, right? And it lets me move. So non-burn, non-injured skin. Elastometric values for burned, scarred skin are as much as 50% less than skin that's not been injured. So what does that mean? Well, let's take a look at our friend here. See the dots on his body? And watch how they move as he moves through a typical abduction range of motion. So what happened to those dots? Okay. So you'll notice that the higher dots moved a lot, right? The lower dots still moved. What this video tells us that in order to do this motion, you need to borrow skin all the way from your low abdomen, right? We don't think about that, right? We think about, well, I need skin right here to move, right? But I need skin from all the way down here. That's going to be really important in a minute as we start talking about scars. So back to this skin elasticity thing for a minute. Oh, my little line took a dive there. All right. So skin at rest. Imagine that top bar is the amount of skin we have at rest. The second bar is how much that skin will stretch, right? That's our 50% elasticity that lets us stretch. Now imagine I have a wound or a scar that is non-mature. Instead of stretching 50%, it now stretches 15, so 1/5. It stretches this much, right? If you're trying to get flexibility and mobility, which would you rather have on your body? And which one's going to be easier for us to deal with as therapists? Now to further complicate that, you think about somebody who has a mature scar, a fixed scar, right? These are the people we're seeing in long-term rehab. Guess what that number goes to? So we thought it was bad when we went from 50% to 15%. A mature scar has a 4% elasticity. This thing will stretch 4% of its length. So this is what we're trying to rehab when we talk about rehabbing a fixed or mature scar. And these things happen really, really fast. So from time of wound closure, we have about 1 to 4 days before that scar starts to form. Really fast. I go home on a Friday, my patient's moving great. He doesn't do anything till Monday morning, and when I come back in, he's contracted, right? That's fast. If you're in an outpatient setting and you have a burn survivor that you work with that you see maybe once a week, and you're wondering why they're getting worse, why aren't things progressing, why are they tighter? I'm seeing them every week, right? They should be doing great. How many days do they have between your treatment that they're tightening up? In a week, we're starting to get tendon shortening. So this happens really, really fast. So think about that video we saw before, right? That guy had normal skin, non-injured skin. We had the dots, and we knew what the dots did. So who wants to predict what's going to happen to these dots? Who thinks they're going to move the same? Should we see what happens? So how do we feel about that? Listen, I've been doing burn 25 years, and when I saw this video, I was like, of course this is what happens. But you have to see it in this format to really understand it. So not only is he not getting as much skin recruitment, it's not even happening in the same plane, right? He's pulling on that right side, that dot's moving out. On the left side, it's moving up. And it all depends on where his contracture is. And if you look really closely, right here, you see that band? And it's really hard to see. But that band is what's keeping those dots from moving. So this is what we're asking our patients to move through and to rehab through. So love this picture from camp because this is sometimes how I feel working with people with scars. Like it all comes at you real quick. There's a lot of things I can't control when it comes to scars, right? As hard as I try, I can't make the doctors go to surgery earlier, right? I can't make wounds heal any faster. I can't control the fact that the wound is there. You know, I can't really, to most degrees, can't control whether my patients do what I ask them to do, right? We can't impact their compliance overall. And I can't control how sick they are. So, and I definitely can't control genetics. I can't control whether somebody may be a scar or not. Can't deal with any of those things. So we just have to figure out how to mitigate those. Despite everything we do, 18 to 50% of all burn survivors will develop scar contractures. So we can't keep them completely from developing. What we try to do is take really good therapy interventions that are research and evidence-based, implement those things to mitigate how the scars develop. One thing that's really important for us early on, and for those of you who are working in the community with people with acute scars, it matters how the bandage is on. It matters every time how the bandage is on. I can't tell you how many times I've walked in a room and a hand has been wrapped like this. How are we ever gonna get this motion if somebody's wrapping them like this 24 hours, right? So I go in with my little pair of scissors, pull them out, fix the wound, get yelled at later by the nurses, but it has to be done right every time, right? Because how fast do these scars develop, right? Can we afford to let them be wrapped inappropriately for even a day? The other thing that's really important is positioning. So we say the position of comfort is the position of contracture. So we're on, 10 hours of this conference? You guys are all kind of slumpy, you're kind of sitting like this. If I told you right now to stand up in the position you're in without straightening your upper body joints, how are you gonna look? Right? If you had a burn, you would have a lot of trouble coming out of that position because you've been sitting here for hours. So if we walk down the hall and we see our patient resting in bed, and every time I go in the room, there's pillows under their knees, their head's like this, they're always turned to the same way, their elbows are like this, guess what they're gonna look like when I get them up to walk down the hall? Exactly like that, right? So I may walk in somebody's room 6 times a day and be like, hey, let's move, let's do this. It may take me 30 seconds, but it makes a huge difference in their path. So those of you who work in an inpatient rehab unit, if you have 5 minutes and you're walking down the hall, stick your head in the door. Look at what position they're in, look at what they're doing. It makes the rest of your time with those people a whole lot easier. And pretty soon you'll get to the point where you can knock on the door and say, hey, and then they'll reposition, right? My favorite one is I'll stick my head in the door. Hey, how's it going? Oh, I'm sorry. And you'll see pillows get thrown all over the place. Good, this is what I want. The other thing we can do is we can be coaches. We can be encouragers and we can be educators. And I think that's really important when working with people who are developing scars, because as therapists, our goal is to make people better. And the goal of scars are making things worse, right? So we have to be able to encourage these people through this development. We know 18 to 50% of people are gonna get contractures. What does that mean? Well, contractures cause increased pain. They cause increased demand on staff because we have to have more splints, we have to have more positioning, we have to have more garments, we may have to have more surgeries. And one thing that a lot of people don't think about is once these contractures develop, your patient is a much higher risk to develop a pressure area, right? Because they don't move the same, they position in ways to try to get comfortable, then you start to see more pressure injuries. They also cause decreased functional movement. They make wounds take longer to heal. They make your splints not fit. You may make a splint today and in a couple days with a contracture, it doesn't fit anymore, so you have to start over. It also makes for worsened outcomes and psychosocial adaptation. How do you think you feel if you have a contracture that's not letting a part of your body feel and move normally, right? That's going to change how your burn survivors feel about themselves. Traditional therapy, that's what we do, right? A lot of range of motion, a lot of stretching, a lot of tissue elongation, myofascial work, scar management, all the things. You guys know how to do all these things. That's what we're gonna do every day, right? But there's some problems with this, and we're learning more about this in burn research these days. So let me ask you a few questions about what we do typically. So if you have somebody come into your gym or into your space, how do you determine if they have full motion? What do we do? You just ask them to move, right? Ask them to move, you evaluate them, you assess what they're doing. If you see a joint and you're like, I don't think that's full, what do you do? Or what should we do? We probably don't do this enough, but what should we do? Right, we pull out one of these, right? So thinking about goniometric models, what is the current goniometric theory based on? So when you measure with a goniometer, what are you measuring? Angles? Angles of what? Angles of joints and what else? What are the things attached to joints? Angles of joints, bones, right? So our current model is osteokinematic or arthrokinematic, depending on who you ask. So this thing measures how bones move around a joint. Fair enough. Sounds like a good thing for therapists to do. The problem is in burn rehab and in scar rehab, we're not interested as much in what happens with bones and joints, right? What are we worried about? We're worried about skin. So we've started looking into this theory called cutaneokinematics. So kind of different than osteo or arthrokinematics, we're looking at its skin movement. So we know that when something heals, when it heals with skin that's not the same pliability, right? We've already talked about that, right? We talked about all this stuff. So this inadequate quality of tissue is making the scars less extensible. So the other piece of this that a lot of people don't think about. So I'm going to borrow somebody's hand because I can't stay in one place. Who wants to be a hand model? It doesn't hurt, I promise. I'm going to come see. Oh, here comes Paige. Come on up here, Paige. Paige Parker Tucker, everyone. Okay, so we're going to take Paige's hand. It's a normal hand, right? No tricks. Flip your hand over for me. I'm going to measure with my handy dandy day measure from the center of Paige's MCP to the tip of her finger. Paige, what number do you see there?
Oh, dude. 8.
8. Okay, now here's the trick. When Paige moves her hand from here to here, what happens to the length of her finger? Does it get shorter, longer, or stay the same? Okay, who says longer? Okay, who says shorter? Some say longer, some say shorter. Okay, so bring it all the way down here to a really tight fist. I'm gonna measure from here and go all the way down and around. And now what number are we at?
11.
11. So we went from 8 to 11. Thank you, Paige. So we went from 8 centimeters to 11 centimeters in length just by doing this. What part of our body has to stretch to let us go here? The skin, right? So we already know that our skin doesn't stretch because we have a burn. And now we're asking it to do something else. We're saying, not only do I want you to move your normal amount of movement, but I need you to move enough to let my bones and joints move. Man, we don't ask for much, do we? So what we've identified in burn literature is this topic called cutaneokinematics, or sometimes you'll hear it called CFUs, right? That's our fancy cutaneous functional units word. But what we've learned in this is we have to think about where skin comes from, how much skin stretches, and where we need it to go when we move. One of my favorite stories to tell is I'm a therapist, so I love patient stories. I had this guy that I worked with forever. He was 36. He had about a 40% burn. Both arms were completely grafted, super high risk for scars. He was a mechanic, though. He was the toughest guy ever. I could have walked in his room and said, hey, I need you to walk from here to here on your hands, and that's what we're going to do for therapy. He would have tried it. He went home, discharged, looked fantastic, went to outpatient therapy, had a great CHT, hand therapist, outpatient therapist who I would refer any patient I had to. They were fantastic. And I got a message, hey, he's discharged. He's going to go back to work. He's got full range of motion. Measured it with goniometer, perfect. I saw the guy in clinic a week later, and I was going to go in and just say hi. I was expecting him to be super excited. He's back at work. He's doing all the things. And I go to see him, and I walk in the room, and he says hi, and he starts crying. And this is different. This isn't how this guy reacts. And so I started talking to him. I was like, what is going on? Talk to me, tell me what's wrong. He said, I'm going to lose my job because they think I'm faking my injury. Okay. I can sit in the therapy room. I can do everything. Every task she put in front of me, I could do. She took her little measuring, he calls it a measuring tool. She took her measuring tool, and I got all the numbers right. But why can't I do my job? So those of you who measure range of motion, when you measure somebody's wrist, what position is their body in? How do you put them? What do our textbooks tell us to do? So typically you're sitting at a table, this position, right? Pretty standard. Is this how he works, though? No. Hey, Zach, show them what a mechanic does when they go to work. So what's different from this than how he looks sitting in the therapy room? So he's like this, right? So this is what he looked like in that typical range of motion position. I mean, he's got a little bit of a wrist extension problem. He's got 42 degrees there. I'm not too worried about that though, right? He has pretty good motion. But when I put him in a position that simulates what he looks like at work, look at what happens. So not only can he not get his wrist extended, he can't even get his wrist to neutral. And you guys see that really white scar band right there? So what do we know about body movement? So he would start to move. He's got his screwdriver, his tools in his hand. He goes to reach under the car. Elbow extends, wrist flexes. What's the next thing that happens? We drop our tools. So could he do his job? Not at all. But by the nature of what rehab tells us and what we learn, we could not find this limitation, right? So this is where this theory of cutaneokinematics come in. Now we know, right? And now we have evidence-based and research that tells us this is what's going to happen. So this new concept, we started working on this. It started appearing in the literature in like 2009. Our big study was 2019, so it's sort of new. But we know there's a positive relationship between the percentage of involvement and contracture risk. So where your body recruits skin from. If my body takes skin from here, so think about the picture of the guy doing this, right? He used skin from all of this area to do this, right? The amount of burn in that area directly impacts his contracture risk. The size of the burn in that area impacts his contracture risk. And what we know and what we're trying to prove is we know that percentage of CFU involvement may potentially be the greatest indicator of rehab time necessary for full recovery, which will be amazing because that will be a predictive model. And we also know that the percentage of CFU involvement is independently related to people who develop moderate to severe contractures, right? So we're trying to predict these contractures before they become a problem. We did a big study where we enrolled over 1,000 patients and looked at burn scar contractures and movement based on a cutaneokinematic model and an arthrokinematic model. Over all of those people, there was a 6% difference in movement when you considered a cutaneokinematic model versus arthrokinematic. So just by putting them in a different position that was receptive to their scars, we saw a 6% increase in their limitations. That's huge. I'm not going to go into a lot of the specific details, but there is a tool that's available that's free to download on your phone if you work with a lot of people with scars. This teaches you those positions, how to put them, how to measure, all the things. And it's called scar goniometry, if anybody is interested in that. But based on that, what we developed is a cutaneokinematic map. So this is my predictive map. So when I have a patient that comes in, they take that little body diagram and the docs are going to color in where their burns are. I can take this diagram and from their burn map tell you exactly where their scars have the potential to develop. So this is our predictive model. This model has given us a much higher rate of increased appropriate referrals. So we're getting referred for the right things, right? This patient needs OT, this patient needs PT, this patient needs speech, based on where their burns are. It also is linking between day one when they come in the door and what they're gonna look like 6 months or a year down the road, because we know where these problems are gonna develop. Really fun thing it's done that I kind of didn't expect. It lets me have these great risk-benefit discussions, because imagine going into a 5-year-old's room with this little person model and say, hey, we're gonna color where your injury is. And then we're gonna use that to decide what we need to do in therapy. They are all about it. It's really fun. It's also really good for students because burn therapy is hard to wrap your head around sometimes, but if you give these students the same thing, they get crayons and they get a model too, and they color in their patient's burns. But it's starting to answer this why contractures develop question, which is the bane of existence for all burn therapists. So let's kind of look at see what this looks like on a case discussion. So this is a mature burn, right? Fixed burn. This is a kiddo that had a scald, hot ramen noodle scald, had a skin graft to his chest. You see some thicker scars in the middle, some of the red ropey scars. Those are less mature than the pale scars on the sides. So we think about his entire chest. So this is the area that I know he needs skin for to do certain movements. So let's put his burn in the middle of that space. So if you're his therapist, what are you concerned about based on this model? So I don't know, can you guys read these numbers here? So what does this burn have the potential to impact? So neck extension. What about shoulder? Shoulder abduction. And there's one more thing. What does this yellow box right here represent? Hip extension. Now that's an interesting piece of this puzzle, because not only does that tell me where his contracture is going to develop, that tells me how to stretch him. So think about that. If I'm working on this motion, right? He's sitting down. I've got lots of extra skin, right? You all know what happens when you sit down, right? You get all the wrinkles. But what if I stand up? All of these wrinkles are straightened out. So I'm taking the same skin. I'm using the same skin to extend my hips that I'm using to bring my arms over my head. So my patient can probably get full motion sitting down. But the second they stand up, they cannot, because I've taken that skin that I'm using to get my arms over my head, and I've transferred it down here to my legs. Now, why does that matter? Because our patients don't function in a world where they sit down 24 hours a day. This really came to light in our US military study because our guys couldn't climb ladders. They had this motion, but the second they went up on that ladder and they stood up and those hips got extended, they didn't have it, right? So we love that we can use this model to not only pick on which motions we need to do, but it tells me how to stretch. In that same vein, if I'm working on getting joint motion and worrying less about contracture and scar stretch, I'm gonna stretch them sitting down, because that lets me have success. It lets them see that they can get that motion. It does it in a less painful manner. And then as we start to loosen up, then we go into supine or we go into prone and we put everything on a full stretch. It also matters how my neck's positioned. If they're sitting like this while we're stretching, that's using a lot less skin than if I put them like this, right? It's a lot to think about, but it's really making a difference in how we're thinking about stretching scars. So with this burn, when I first started doing burn rehab, who do you think would have been consulted for this patient? Probably plastics. Therapy-wise, man, we don't need therapy. It doesn't cross the joint. He's gonna be fine, right? That's what we thought. But now we know we probably should have OT and PT, right? Probably we'll still have plastics at some point. We're worried about more movements. We're worried about more positioning. We've already talked about the potential implications for ADLs, right? This kid was a football player. He wanted to be able to run and play and toss, but he couldn't do that because of this tightness. And the other thing is, what happens as he grows? So what does a scar do when he grows? Our skin has to stretch as we grow, right? Our skin elongates as we grow. That skin is not gonna stretch the same as non-burned skin. That scar will always be that size. So he was burned when he was 3. He was burned from here to here when he was 3. He's 8 in that picture. His scar has stayed the same size. His body has elongated, right? And as he continues to grow, that scar is still always going to be that size. So it's going to have different problems for him as he gets older, but it's never going to have the same stretching and the same flexibility. So we talked about this problem of scars. So these scars that get thick and red and raised and painful and itchy go from a scar contracture to a hypertrophic scar. And these hypertrophic scars are the ones that give us the most trouble, right? These are the ones that hurt. These are the ones that have that 4% elasticity and just do not move. They can be really big. You can have a patient that has hypertrophic scars over every piece of their burn. But there are some things we know that make them better. So pressure's the big one. For the last 4 decades, we've known that people should wear pressure garments, right? Have you guys ever had a patient in a compression garment? Right? They're tight, they fit like a second skin, kind of itchy, kind of uncomfortable, but they make a huge difference. We apply pressure with garments, with inserts, gel sheets, elastomers, whatever we can get to stick on there. There is still some question in the literature about the cost benefit. A complete pressure garment suit for patients, $3,000 to $5,000, right? It's not cheap. And they have to be remeasured about every 3 months. They have to be remeasured with growth. The second thing that we know works is heat. So think neutral warmth, not so much heating. If we increase the skin surface temperature by 2 to 3 degrees, we start that scar in a process of breaking itself down. So inserts work, garments work. We're really trying to prevent surface cooling. We did a study in 2011 looking at neoprene, and neoprene is the stuff that we make wetsuits out of, right? Those of you who have worn a wetsuit, what does it do? It creates a moisture barrier between your skin and the suit, and it heats that water, heats your skin, so it keeps you warm. It does the same thing with people with scars. And the other thing we have to do is keep them really well hydrated. If you ever see someone with a scar and their scar looks dry, get moisture on it before you do anything else, because it can't elongate if it's dry and crusty and itchy. A lot of people just say, I have a scar, that's cool, I'll just have surgery and fix it later. I get that a lot, especially early on. I don't want to do therapy, I'm just going to go to plastic surgery later and fix it. Our rule is if we do long-term surgery on someone, it is to restore deformities, right, that impose functional limitations. We're not working on cosmetic scar fixes. Now, there are people that do that. There are plastic surgeons that focus strictly on cosmetics. Our goal is to get them moving. And those surgeries can't happen until recovery from their initial phase of injury. So this may be 6 months to 2 to 3 years after their original injury. So what's happening in the meantime to the muscles and tendons and ligaments, right? Just because you fix the skin, you don't fix those underlying problems. There are levels to reconstruction options. We start with laser resurfacing to injections, all the way up to flaps and grafts. So depending on how severe a scar is, that's going to tell us what we have to do. But in the long run, despite all of this, we really, as therapists, can make a huge difference in the recovery. So this is a kid that we worked with for a really long time. He was 15-year-old, he was in high school, or getting ready to play high school basketball, was super excited about it. He was out with grandpa burning leaves and somebody threw gasoline on the fire. Because Arkansas, and that's what we do, right? Don't do that. Also, caveat, kerosene blows up as easily as gasoline, so for those of you who think it doesn't. But he got a burn, right? Got a burn, got a scar. That is a pretty functionally limiting area. That's his axilla, right? What does a basketball player have to be able to do, right? The thing he couldn't do. So he comes to us, he's very compliant, does everything he's supposed to do, but that scar's just not getting better. And if you guys can tell on the color, it looks really pale and really blanched out, right? That's because he is at the extent of his range of motion. That's as much mobility as he has in this space, and he's trying as hard as he can to go higher, but he can't do it. So let's put this in space. So remember our little picture here, our little friend. Let's throw his burn on it. So what are we concerned about for him? It's pretty similar to that last burn. The question we have to ask ourselves here is, are we concerned about shoulder abduction at that left shoulder? So it's really easy when this kiddo comes into clinic to spend all your time on that right side. And we tend to do that. We tend to get really focused on the joint that's burned, right? The joint that's involved. But that's, again, is all one piece. It is all attached. So if we're not stretching that other side, he's never going to get his full elongation. Think about, we talked about when we're stretching somebody's shoulders and they have hip involvement, like we want to be supine, right? So what position do I want to put my left arm in if I'm stretching my right side? What they want to do, and how many of you have seen this? You've been working with somebody's shoulder and you look over and that other arm's here, right? We're stretching this and he's trying to help, so he's going to cheat and he's going to bring this skin all the way over. Sometimes they'll even cross their leg over because they don't know they're doing it, but they're trying to give you extra skin to work with. So I want this other arm way out here, and if I have the chance, I'm even going to hang him off a mat like this. So as much stretch as I can get here. I'm going to get these legs starfished out, right? I'm going to get him really open. If I can, I'm going to lay him back over a therapy ball. Right? I want as much stretch on this as I can get. So it does matter what's happening to the other side of the body. And when we look at this model, what you'll notice is it doesn't differentiate between left and right. It doesn't say we're only concerned about the left or the right, because your skin's all attached. So what were we doing for this kiddo? So we talked about pressure. So he was wearing garments. He'd been in garments for 3 months, and this is where he still was. So would we consider that garment success or fail? Kind of hard to know, you know. The scar's still active, so the garment may have kept it from getting worse. But that area is really, really hard to get consistent pressure. Because what happens when you move? Like, you think about your armpit here, it's going to gap, right? You're not going to hold pressure on that all the time. And it looks different, your garment fit looks different when you're standing, when you're sitting, versus when you're moving. So it's never the perfect solution for axillary balloons. His garment is providing him some neutral warmth. And he's great with his hydration. This kid was probably the best. Teenage boys do not like lotion. This kid was probably the best at putting his moisturizer on as anybody I've ever seen. Like, he carried it in his pocket, which was amazing. His scar looked really well hydrated. That doesn't look like a dry, itchy scar, but he still has problems. So what do? Do we go to plastics and say, recon, open it up, let's cut it out, let's start over? We could. But what we did instead is we said, can we have a month? Let's see where we can go with this kiddo in a month. And so we escalated our scar management, and we tried to increase those things that we know make scars better, right? So what are the 3 things? Pressure, moisturizer, and warmth, right? Hydration and warmth. So we took our neoprene, which we already know gives us those things. Because of the way his scar looked, we didn't try to put it right in the center of his axilla because we already know it's not going to stay. So we treated the 2 stiff ends of his scar. So we put a piece of neoprene on his upper arm and a piece on his chest. And we said, come see us in 4 weeks. So how much progress can we really make in 4 weeks with a scar? This kid's been in garments for 3 months and he still looks like this. So what do we think is going to happen in 4 weeks? Actually, a lot. So this is what he looked like 4 weeks later by increasing the 3 things that we know make scars better. Had we just increased one of those, we probably wouldn't have gotten the same outcomes. But you'll notice that this scar is red. That's because he's not at his full stretch. When he came back in 4 weeks, he could raise his arm above his head, right? We changed his stretching method. We talked about how he had needed to position the rest of his body in therapy, increased his hydration, his compression with that added neoprene, and we increased the neutral warmth, and he looked like that. In a month, he looked like this. So is this a kid now that needs to go to surgery? No, right? 1 year later, he looks like this. So this is why what we learn and what we know in evidence practice makes a huge difference, because they wanted to take this kid to surgery. And had we taken him to surgery,